talk.
I think a great talk with all the right things said.
Yes.
I think it's been repeated. Most in a repetitive fashion. We've gone through all those things through the whole day.
So I follow on from my good friend Dr. Shaby's talk, where he talked about the 10 commandments from heaven through to hell, what you shouldn't be doing. So this is going to be a talk really talking about some data around bifurcations. I've elected not just to focus around left main, but to show two illustrative cases where I think that imaging is particularly useful in these cases. I personally image in 100% of cases. Every case that I do will either get an OCT or an IVUS at the start, often in the middle and at the end of the case. So why are bifurcations important? Well, this is some data that we've published from the Ultimaster registry showing that bifurcations have much worse one-year outcomes for a variety of different endpoints, such as target lesion failure, target vessel MI, stent thrombosis, and so forth. This is some work that we published around complex PCI, and the major take-home message from this is that bifurcations with two stents have the highest event rate. You can see that they have the highest target lesion failure rate and the highest target vessel MI rate. Therefore, it's really important in these cases to undertake intravascular imaging. As we've said, I think imaging is mandatory in left main cases. We've published data from the UK showing with 30% reduction in all-cause mortality at 1 year associated with intravascular imaging for left main PCI. It helps you understand the plaque burden in main vessel and side branch. It helps you define bifurcation angles, particularly when the angiographic views are suboptimal, and helps you characterize calcium, particularly whether it's circumferential, the depth, and as we've seen in many of the cases today, guide lesion preparation and use the appropriate tool for the right indication. And this is the data that I talked about, left main intravascular imaging, our paper showing a big reduction in mortality. I think when undertaking PCI for bifurcations, whether it be left main or whether it be non-left main, you have to individualize your approach. This is an editorial that we wrote with Mirvat Alasnag from Saudi Arabia that couldn't join us this time. And really your decision-making should be around whether it's complex or simple. If it's simple, then probably go for a provisional approach. If it's complex, I think a two-stent approach. I don't think a DK crush is one size fits all. There are many other techniques, and you should very much individualize it depending on the characteristics of the main vessel and the side branch, angulation, and so forth. So this is the first case I want to talk about. A male patient, 47, ex-smoker, who's come in with this lesion. Fairly straightforward looking lesion, not much calcium there. The bifurcation angle of the diagonals, again, relatively straightforward, a 111 Medina. I elected initially to undertake a provisional approach in this case. So went provisionally, I did an OCT, size 3.5 distally, 4.5 proximally. I deployed the 3.5 by 28 millimeter stent in the LAD, potted with a 4.5 balloon. I'm not going to show videos, it's a straightforward case. There's the pot. The side branch was nipped, therefore I elected to do a final kissing balloon before potting again. This is what I got, and this is where imaging is really useful. So you can see that there's TIMI3 flow in the side branch. Many people would say, well, great result, stop there. As I said, I always OCT everything, and this was no different. So I OCT'd this. And this is an OCT going from the main vessel into the side branch. And you can see that an extensive dissection in the side branch, as well as an MLA that's only about 2.5 millimeters squared. And you can see that, the dissection extends quite far into the side branch. And a really nasty looking dissection. I don't think it would be appropriate to leave this. So immediately you can see that imaging has really changed how we're thinking about this case. So I undertook a T with a tap. Again, I'm not going to show videos, it's straightforward. And this is the final result. And I'm going to show you some more OCT. So this is the final result, good looking OCT result, a good looking image result. This is the OCTs, and the OCT is very useful here. Why is it useful? Well, first and foremost, it helps you check the results. You can see from this that In the TAP, you can see that the stent has come into the main vessel, but not so far in that it's compromising or reducing the lumen. This is the 3D reconstruction. And again, you can see that your ostium is well covered, and you can see the stent coming into the lumen. This is the fly-through, which I think is a very nice way of using your OCT. It's 3D reconstruction. And you can see here that in your T with TAP, you've got some protrusion of your stent into your main vessel. And you can also look at all individual struts here, see whether there's any malapposition by looking at red. You can look at the distal edge of the stent, make sure there's no edge dissection. I often use this 3D reconstruction, particularly when I'm wiring bifurcations, because it gives you a very good idea of whether you're wiring distally or more proximally. So I think it's a great use of OCT in a bifurcation here. Here is some considerations with T with TAP. I think it's a good technique. I think you should aim for the shortest possible carina with TAP. And I think the most important thing is when you pot is that you don't reach the neocarina, because you'll end up crushing the side branch stents. You've got to be very, very careful. Use stent boost. Here's another case. Now, you may say, well, why are you showing us this case? This is a really simple ostial lesion. This is a case of a patient who came in with an acute coronary syndrome. Many will say, this is not complex. I'm going to show you some data to actually show this sort of case has the worst outcomes of all bifurcation lesions. So the 001 cases have by far the worst outcomes. I will show you a paper, which is the first in the literature to look at this specifically, that hopefully is going to be published in the next 3 or 4 weeks from my group. Is this the case? So I elected to predilate with a 2 millimeter balloon to create space for OCT examination. And you can see that in the distal vessel, distal side branch, a big vessel, 3.5 millimeters. You can see that at the ostium, just before the main vessel, very tight. And you can see that it's a 5 millimeter vessel. Now, there's many different ways of treating this. Of course, you could use a diagonal to LAD approach. You can then do a KISS. You can use a 2-stent strategy. But I want to also show you that you don't need to use a stent in these sorts of cases. And what I elected to do was use a 3.0 Wolverine cutting balloon and then a 3.5 drug-eluting balloon for a minute in this case. And this is the final result, so actually quite a reasonable result. And this is the OCT. So there is a localized dissection that you can see here, but the MLA is actually pretty good, and I don't have a fear of this closing down. So I was happy to leave it, and the patient was stable. And this is really why I want to say that really for these 001 lesions, I mean, we often see them. I would say that if at all possible, avoid using a stent in these lesions. And I'm going to show you the data why I think you should avoid stenting these lesions. And if possible, if you're going to treat them, use a balloon, a cutting balloon and drug-eluting balloon. So this is a paper where we've analyzed 4,000 bifurcations and the distribution of disease. It's the first time in the literature anyone has done this. This is going to be published in probably the next 3 or 4 weeks in JAHA. And you can see that isolated side branch lesions account for about 3.5% of all lesions in side branches. This is from the Ultimaster registry. And this is really the take-home message. You can see these are Kaplan-Meier plots of all the different Medina distributions of disease. And you can see that the one that has by far the worst outcomes, so a 5-fold increase in the risk of target lesion failure, cardiac death, target vessel MI, and target lesion revascularization are the 001 lesions. So, these are not benign lesions, stenting them. These lesions, if at all possible, avoid stenting them. This is 4,000 bifurcation lesions showing that they have the highest risk of target lesion failure and cardiac death out of all bifurcations lesions. Much worse than the 111s that we often consider to be the most complex. And so in summary, in my view, the choice of 2-stent approach really depends on anatomy. You need to think about the angle of the side branch, the size difference between the side branch and the main vessel, and the experience of the operator. We often talk about DK crush. Let us not forget, for those entering the DK crush trial, these were people that did over 300 procedures a year every year for 5 years. There were people that did over 50 left mains every year for 5 years. And they also had to have their DK crush case assessed by a committee, and only then were they allowed to enter into the trial. So the results that you see from DK crush trials are from highly experienced, very selective operators. The vast majority of operators, myself, in this room, will not meet those standards. And so it isn't clear to me whether we can achieve those sorts of results in the real world. 001 is associated with the worst outcomes. It's not a benign lesion, much worse than 111 lesions. So if at all possible, avoid stenting these lesions. If you do need to fix it, then I think cutting balloon, drug-eluting balloons are very reasonable. Use OCT to look at the distribution of your dissection and your MLA, because a lot of these cases, if you get a good angiographic result, is safe to leave alone if you OCT. I think you should use imaging in every bifurcation case, particularly in the ostia, where most restenosis occur. And I think imaging is most useful to do it up front, in the middle, and at the end, because often it will change your management plan, as I showed in my T with TAP. Okay, so thank you.
I'll request Dr. Bhupati to step up for his presentation, and Ashok wants to take the.
So I think that, Mohammed, that's great concepts around two-stent strategy or provisional strategy. A couple of points and then a question to you. Firstly, of course, that the ostial lesions of a side branch are truly very difficult because you end up, if you do anything more than just a balloon angioplasty or a cutting balloon as you demonstrated, if you stent it, you actually sacrifice the main branch.
Yes.
And that's not a good thing.
Correct.
But I think in imaging, I think we need to emphasize that you always have to image what looks like the normal main branch as well.
Yes.
Primarily because if there's a bulk of plaque sitting there, then you change your strategy into what could be a two-stent strategy, what could be a cool-out, what could be any two-stent strategy. So I think it truly, the main branch imaging is equally important than just the ostial side branch imaging, which on angiography you think is 110, but may actually be 011 actually.
Yeah, completely agree. And the other thing to say is never try to nail the ostium. It never works.
It never works, yeah.
So don't do it.
The second aspect was, are you a very hardcore provisional strategist, should we say, especially for the left main?
No.
Because I've seen operators who, even going by the definition criteria, would still not go by the definition criteria and just proceed to provisional strategy and falling back all the time on a bailing out of the side branch, which actually has a worse outcomes than upfront two-stent strategy.
No, I agree. I mean, I'd say probably for most of my left mains, just because of the case mix that we have in my area, we have very elderly, multimorbid patients. They tend to be very calcific disease. It's very rare that you can get away with a provisional. I don't particularly do DK crush in all the cases. I think that part of the reason why they have worse outcomes in the Kilot arm, for example, is that most of the restenosis occurs in the ostium of the circumflex, and that's because people don't prepare the ostium properly. So in those sorts of lesions, I always use cutting balloon to make sure I have a good MLA, and again, image both arms at the end, and if necessary, use more aggressive balloon dilation to make sure that you've really got the best result.
Yeah. So simple for simple and complex for complex.
Yes. And that was the main difference between EBC main and the DK crush trials. I mean, many people say, well, they show different things. They don't. If you look at the average side branch length of EBC main, it was less than 10 millimeters. So by definition, it would be a simple bifurcation, which of course provisional is indicated for. Whereas in DK crush, it was, I think, about 15, 16 millimeters, the average length.
Excellent. One last comment from Henny, and Dr. Bhupati, would you like to step up? No.
Thank you very much. I just want to point out something, that you're in a position to teach, which you just did, which is quite unique. Because, for instance, where I practice, it's impossible for me to use an OCT in a side branch to avoid putting a stent, where the price of this OCT is about 4 times the price of the drug-eluting stent. So, from a practical point of view, I can only see those things and learn, especially with data of 4,000 stents. And I don't know, probably most of the people in this room also would find using an OCT in a diagonal to avoid stenting it in our
Yes.
part of the world might not be applicable. So it's very good to see it and to get those levels.
So I would say to that that we're trying to publish a cost-effectiveness analysis of every PCI case in the UK, where we're looking at the cost with 1-year outcome data of imaging versus no imaging. Again, this only applies for the UK because we work in different systems. The costs that we use in analysis are different. But for the UK, use of IVUS is cost effective. You save more costs using it in every case than not using it because of the reduction in target lesion failure, restenosis, having to bring the patient back to the cath lab. That's costly.
Thank you very much. Thank you. A big hand for